Good morning and welcome to Digimed TV. Today's theme is elderly care and assistive technologies. We are still waiting for our first guest to arrive in the studio, Keming Zhu, and he's due to talk to us a little bit about some of his technology for elderly care. But in the meantime, I thought I'd indulge myself and play a little video about Old Lives Matter to give some sort of perspective to today's program. Now I've gotten older, I've lost my hair many years ago. Hello, I'm David Wortley. I'm the CEO and founder of Digimed TV, and I've been asked to talk to you today about the theme of Old Lives Matters. Sorry? What? What do you mean, not Old Lives Matters? What? All lives matters. Oh, I thought you said old. No, I didn't get the email that you sent. Anyway, my eyesight's not too good, so I do have a bit of difficulty reading emails. So you definitely said all life matters. And you want me to talk about that? I thought you were trying to promote the Digimed TV broadcast next week on elderly care and assistive technologies. Oh, well, why can't I talk about All Life Matters? Yes, I do believe that all life matters. Why can't I talk about Old Life Matters? Because people will think I'm prejudiced because I think I'm a victim because I'm an older person. Is that what you say? I don't know. Younger people, they are very politically correct. Anyway, if you're still watching this video, I want to begin by making something extremely clear. I believe that all lives matters. It doesn't matter what age you are, what sex you are, your cultural identity, whether you're rich or you're poor, whatever your background, whatever your belief, all lives matters. I'm going to stop the video there because we're been joined in the studio by our first guest, Keming Zhu. And so I'm going to invite him into the studio now. And I'm going to begin, Keming, by asking you to just introduce yourself and say a little bit about your background and about the company that you have here in the UK.
All right. Good morning, everyone. Thank you, David, for inviting me to join this talk. My name is Keming Zhou, and Keming I come from a company called August International Limited. It's a UK-based and private limited company. And recent years, we run a research program together with the University of Essex. The program is funded by Innovate UK and a program called KTP, Knowledge Transfer Partnership. What we have done, we have recently developed a few technologies for wearable and the market and the devices, especially for elderly care. So, I've been pleased invited by David to share some of our research and progress and the technology and device. Thank you.
So this research program, was it designed to develop a specific product? Can you just say something about the objectives of the research program?
Yes, and the first research program we have developed the technology and this algorithm for fall detection. The fall detection means the technology can be used for wearable device and to detect the falls, and the falls very common, and especially for elderly or senior citizens. And if it's not being timely and cared or rescued, it may cause very serious consequences or the injuries or even deaths to the people.
Yeah, so it's designed to detect falls, and I certainly can identify with that because I live with my partner here, and her 96-year-old father lives with us, and he came to live with us because he was having some difficulties, which included falls. And he hadn't been with us probably for any more than about 2 or 3 weeks. And in the night, he went to the bathroom and he fell. And we could hear him shouting, so we went down to see him. And because of where he was, it was almost impossible to lift him. So we had to call the paramedics. But if we hadn't been in the house and if he'd been living on his own, it would have had very serious consequences. So can you just say a little bit about how this fall detection works and what actually happens with the wearable device? What does it do? Who does it alert?
For our device, and we have number one, and the fall be detected if there's a wristband. We have developed the wristband. It's the third generation of products now, so if people wear that, and if had a sudden fall, and it will detect the fall with 92% of accuracy. And that is number one, so detection. Number two is communication. Who will be alerted? And our device use the latest and narrowband IoT, Internet of Things technology. So once you have a fall detected, you need to have an alert and passed to the parties. So our device, we can send the message to the family members, multiple. And because it's IoT and telecommunication or internet access, that also can be sent to the service providers. So we'll be talking to like Caroline 365. It's the UK-based and the rescue or the emergency call centers. So the message will be alarm will be or alert will be sent to various and parties who would be and be informed, and there's a fall happens, and they would launch a rescue or scheme or program.
So it alerts people. You mentioned that it uses narrowband technology. A lot of wearable devices rely on a mobile phone for communication. So this doesn't rely on a mobile phone.
No,
it will send communications direct. Is that correct?
True, and even better because of mobile phone use simply Bluetooth. And the problem is, and if you want to use the mobile phone.
Okay, we seem to be having a bit of trouble with Kemming's audio there, so I'll just wait to see if it frees up. Sorry, Kemming, we lost you there for a second.
Yeah, I mean, what I'm saying, and it's the mobile phone, and you need to use the Bluetooth to communicate between the wristband and the mobile phone. But Bluetooth is not that reliable. Mainly, your app need to be always on, switched on. So that prevents people using the mobile phone to send alerts to the parties to the people. So, and another one is using 3G, 4G, and telecommunication service. That can be possible, but that is very power consumption is very high, and running cost is high. For narrowband and IoT, and we have this. We work together with Vodafone, and it's the NB-IoT is widely used for people and reading meters, electricity, water meters, but applied to mobile device, and it's only recently. We are quite in front. We are quite advanced in pioneer position. So
I can understand that certainly is important. And what you mentioned, power consumption, battery life can be a problem with some wearable devices. So, what sort of battery life can you expect, and how often would these devices have to be recharged?
we at least can achieve under 1 month, and mainly depends on how big the size you want your wristband. And but by all means, like the Apple, and only 1 day you need to recharge it. But for our device, and we can achieve 30 days. Not because of the narrow band, and they consume much less and electricity than 3G or 4G.
Okay, well, thank you very much for joining me this morning, Kemming. I can see our next guest waiting in the studio to join us, Lucia Panese. So I'm just going to bring her into the studio now and say welcome, Lucia. And thank you very much, Kemming, for joining us
Thank you,
today.
David.
And we will keep in touch. Thank you.
Yes.
Good morning,
Hi,
David.
Lucia. Good morning. I know you've been on a guest before, but not everybody will be familiar with Imaginary. So, with you, I'm going to crave your indulgence and just play the rehability sting, because I think this is relevant to what we're going to be talking about.
Okay.
So, Rehability is a suite of products, and I think it's important to emphasize the fact that this is a CE marked product. So it's something which is used in conjunction with skilled physiotherapists. Can you just say something about the background to rehability and the development process, particularly the idea of collaborative design?
Yes, thank you, David. So rehability is, as you said, a suite for telerehabilitation, which is using gain potential to offer motor as well as cognitive stimulation and exercises. Of course, the development process went through a thorough scientific studies with specialists, this is clear. But as you said, the most interesting part was so-called participatory design, which means co-designing each single game together with the target group. And since the medical device is the neurology version, and as we saw in the video, we've been working with elderly patients up to 95 so quite old, sometimes impaired people. It was very, very interesting to work with them to translate traditional exercises into interactive games. So there, what you have to do is investigate their motivation very much. So understanding what their difficulties are, what they want to refer to, what they accept, and particularly what interest they have. This kind of rehabilitation is very frustrating. It's fragile patients who are they're really feeling like victims, very often. They have pain. They suffer a lot of pain, and they get very tired doing exercises, but also doing very normal things. So what you want to do is divert their attention so that even training can be something even enjoyable if you can. So what we worked on was investigating their motivation. And this goes a lot through autonomy at home. So in other words, these people really want to have, if you want, more dignity in their lives. So really being able to cope with very normal things like putting away their cup of coffee after they drank it on their own without having always somebody intervening and supporting them or even doing it for them, which is very, very frustrating. So the exercise went through this whole process, and it was really, for us, sometimes even an emotional process to see how much these people put their hearts into the work they were doing with us and how much they enjoyed it. So, for example, they were super interested to know after the game if there was there had been a day where their performance had been better, for example. So their own record in the same game is something they asked us to have. So they keep quite a close eyes on themselves, and they want to do better. They want to improve. They want to see they can do stuff. So for them, for example, it's much more interesting to play a game where really they put away colorful cups in a cupboard instead of shooting after hands like we saw this example. It's not something that I'm saying just to make a fun example. It was a game that some neurologists had found. So shooting after hand had a right movement for the arm, which was useful to train these patients. But they were not interested because their aim was not to play. Their aim was to become autonomous again. So changing the scope of the games and the setting was something that they enjoyed quite a lot. And maybe I can tell just quickly, the very first time I experimented the games with some elderly people. Normally, it's not me doing that. We have psychologists to do that. But one of the very first cases, we went to Sardinia with our lead psychologist, and I wanted to see how things were happening. So we were there to train the staff, actually. And actually, these people played the trick on us, which was a little bit shocking at the beginning, because they said, wait a second, we have some patients here. We bring them in and we do that, the training together with the patients. Honestly, we were not prepared. So I was scared, I admit it. I was scared because I thought, the trainers, the physios are those who know the patients. We are not trained as physios. How are we going to deal with these patients? So we set the games on very, very easy, simple levels. And we try to let them play the games. And I was really shocked because they were on wheelchairs and they were looking depressed. The situation was not easy. The atmosphere was tense. But once they started playing one at a time, the physios were supporting them on the motivational side. And there was this old lady who was super excited to having something different to do on that day in the hospital. And, the atmosphere changed dramatically, and it was like a party in the end. Everybody was clapping and they were cheering. And then she said, you made me do the most difficult exercise. I know that. And she laughed all the time. It was really so emotional to see them dealing with these games that I was really feeling we are doing something useful that goes probably much beyond physical movement here.
Yeah, I totally agree with you. And I'd like to make a point here, and that is that I chose the theme for today as being elderly care and assistive technologies. And those just two phrases make the assumption that old people need this care and assistance. So it's based on the premise, which I think is false, is that old people need to be looked after rather than giving them something which challenges them and motivates them to improve it. And you've just verified by what you said, this this idea that old people really want to be able to do things from themselves. They don't want to be given things all the time. They want to be able to feel capable of doing things on their own basis.
Yes, that's so very true. They want to be autonomous. They want to be challenged. Of course, all these things, I mean, technology is something new for them. They are a little bit scared at the very beginning, but as soon as you encourage them, and if they see it's designed for them and they can choose the pace, then it's fine. So I really want to stress this point, because even today, I mean, we're 2021. There are some people saying, but you cannot put technology in the hands of elderly people. They're not digital natives. Well, of course they're not, but the technology needs to be designed for them. And to do that, it needs to be designed with them. And this makes the huge difference. And then you find enthusiast users.
Yes, and I think this whole idea of bringing together gamification and technology is very important. And although the origins of rehability were based on rehabilitation, people who've had suffered from strokes and Parkinson's disease, the games themselves are enjoyable and usable in their own right.
Yes, that's true. So we have also version for active aging, for example. And as we said 1 or 2 weeks ago, we were discussing with you also cognitive issues and mental health and so on. Similar games we're using in the Stage project, for example, where we study how to preserve elderly workers and keep up their cognitive functions and mental fitness, I could also say, so that these people are keeping fit even in as workforces for much longer, because they are needed in companies. So it really depends on how you offer them. And I didn't say it before, but every game that we produce is based on parameters, and there's a dashboard behind the lines, so you can make it in a sense easier or more difficult in very many meanings of the terms difficult. So duration, speed, number of elements, semantic categories. So you can really tune it for very many stages. And this is very useful and interesting.
Yes, I think that's also very important, is that the technology that you've developed, both for physical and for cognitive conditions, is something that can benefit people who who are not what you might call disabled, but people who still want challenges in their life. And I know, if you take my own example, I made a big difference to my personal fitness by walking and challenging myself every day. So these devices, these solutions do not necessarily need to be CE marked. They could be used as motivational games in their own right. And presumably the Stage project doesn't rely on a CE mark.
No, it doesn't. The CE mark is a discriminant for the use that you make of such games. If it's a motivational support, then you don't need any CE mark. If you need to make, say, clinical decisions, for example, changing a rehabilitation therapy, then you need the CE mark. Then you need some more guarantees. The other one is more like an autonomous use.
Yes. Yeah, so I think there's a huge amount of potential for this gamification and physical and mental exercises. And I know we've been talking about rehabilitation and the solution that you developed for use in a wider population, for example, with care homes or people have people like Home Instead who have care in their own homes. So in that sort of circumstance, when you have carers who are not medically trained, how would you handle that situation in enabling them to be part of the solution so that they can offer this as a service to their clients?
Well, I guess it very much depends on what kind of target group you are aiming at. Because if it has to be a sort of therapy, so if it's still rehabilitation, you need a specialist somewhere behind the lines, being a physio or a specialist doctor, for setting up the rehabilitation journey, so the training path for the specific patient. And then you can leave everything in the hands of the carer, because actually there's really little to do, because in the end you press on a remote control, you just press a button, and then on the TV you can see your rehabilitation plan, but set by a specialist who is also remotely reading and checking the data, so the analytics sometimes. And then these specialists can make decisions if they need to change the therapy. So the carer is just a support at home to remind the elderly patient to do the therapy, maybe to encourage them, to have a little bit of the socialization effect that you might want with games and the on the other line. But the medical part, you have to leave in the hands of the specialists anyway.
Yes, I agree with that, and certainly if you have someone who, for example, like my partner's father, he is mentally very alert, but he doesn't get enough physical exercise during the day, and so but he has a carer come in to help him get dressed in the morning and also help him to bed at night. So to give people an idea of what the solution looks like, it's a little box that sits on top of the television. So it's plug and play. Can you just say a little bit more about that?
Yes, it's this little box where we install the license, and it has a RGBD camera, which is a camera able to read a patient's joints. So in other words, with normal movement, without the need of wearables, without the need of holding anything in your hand, you just stay or sit, even in the wheelchair, in front of your TV, couple of meters, not more, and you do movements to interact with objects that are present on the screen. So it's something that is plug and play, and via the internet, it reads data from the server and it sends them back. It needs to read them because the specialist could have changed the therapy plan. So the system locally needs always to know the latest version of the parameters to use. And it sends back usage data. So in real time, the physio could have the new situation. I say could because there's no need for a physio to stay every minute in front of an analytics area, of course. So it's very small, and you can use it for a patient at a time, and then you change it for the next one.
Yeah, so it's collecting the data, and I think, as you've referred to earlier on when you were talking about the reaction of the people who co-designed the product with you, they do like to know whether they're improving or deteriorating. So collecting this data and providing feedback, that's important for them.
It is very much. Only data are on two very different levels. So patients get in real-time feedback when they do action. So if they, for example, collect the right object, or if they put it in the right place, they see stars, they hear a good sound, they see scores going up. And at the end of the game, they have their own score. And the score is compared to their record in that game. So they have immediate feedback about how they're performing. The data I was talking about that are sent back are actually more precise, and they give a physiotherapist or a doctor the idea of the overall progress over time, and also very much in-depth ideas of how the patient is moving when errors occur. So you can infer if it's possibly a motor issue, an issue about attention, an issue about getting tired because the game is too long. So everything that can bring you to medical understanding gets into the analytics area. Everything that is much more game related in terms of am I doing well or not is for the patient, and it comes in real time.
Well, thank you very much for joining me again this morning, Lucia. I can see Steve Gardner waiting patiently and studiously in the background, so I'm going to add him to the stream now and say thank you very much, Lucia. It's always a pleasure to talk to you you and say welcome, Steve. I'm going to, before we start the conversation, I'm just going to play your little video introduction.
Precision Life is a precision medicine business. We have high-resolution patient stratification tools that allow us to get under the skin of complex chronic disorders. We use these tools to analyze large-scale patient populations and get novel insights into what's actually driving disease. Here you can see schizophrenia, a disease that's incredibly difficult to treat and to get patients onto the right set of medications because it has so many different causes. You can see here subgroups of patients with different colors, and the tiny little dots represent the mutations that are associated with the cause of disease for each of these patient populations. What drives disease in the pink population is different from that driving disease in the red population, and that means that the drugs that they respond to, their disease risks and their progression rates are going to be different. We use this to discover novel targets. We use it to identify patient stratification biomarkers and for clinical decision support, identifying which medicines are most likely to work for which patients. Crucially, we also use it to deliver personalized digital health tools to patients. This is our population to personal mantra, understanding at high resolution what drives disease, delivering clinical decision support tools, and digital health apps to patients. In this case, around precision nutrition, allowing them to understand for multi-morbid polypharmaceutical patients which foods are going to work with their drugs and diseases to give them the best possible health outcomes. And of course, we need to put that in the framework of measuring progress with digital biomarkers, wearables, and gamification to achieve the best outcomes in healthy aging. I look forward to speaking to you. Thank you.
Well, thanks very much for that, Steve. That pretty much says it all. But can you just sort of just say a little bit about yourself and your background and Precision Life in general?
Yeah, well, thanks for inviting me on, David. Yes, so I'm Steve. I'm CEO and co-founder of Precision Life. The company's about 6 years old, and it comes out of my background. Many years ago, I was involved in bioinformatics, which was bringing together data to try to discover new drugs. And we moved from that into drug safety, and around about 20 years ago, I was heavily involved in the original Human Genome Project. Obviously, the promise of that was that we would be able to know more about patients and use that information to improve their health. And I think, you know, in some respects that's happened. In some areas more than others. It's perhaps been more influential in oncology and rare disease, but hasn't had so much impact in those diseases that affect healthy aging. You know, when we get into dementia, when we get into diabetes, when we get into rheumatoid arthritis, it's had much less of an impact there. So knowing that there was always going to be a lot more data to be collected about patients, we went into the business of trying to analyze it to get those insights into what was driving disease. And that's really the motivation behind Precision Life and in fact myself. And we're pretty active now. You can see behind me a number of similar disease analyses that we've done across things like Parkinson's, motor neuron or ALS, Alzheimer's, rheumatoid arthritis, Sjogren's, you know, a whole bunch of these types of really difficult to treat diseases.
Yeah, and they're wonderful pieces of art in their own right. I think they would grace anybody's wall. I would think. So, and this is very important because in a couple of weeks' time we're going to be doing a session on nature versus nurture. So the whole objective of this is to provide personalised medicine. Can you just say a little bit about the problems of comorbidity and some of the issues that we face with complex medical prescriptions and how they interact with each other?
Yeah, one of the big challenges is that, of course, it's great to segregate patient populations on a disease by disease basis. You know, I might put you squarely in the yellow block, just over my right shoulder. Sorry, depending which way you're looking at it. But no patient ever presents in exactly the same way. We have different demographics, we have different ethnicities, different epidemiological and environmental factors going on. As you rightly say, you know, we have predisposing comorbidities that change the risk of disease or the severity or perhaps the particular type of symptoms that we're going to see. And so you have to consider the combination of those effects when you deal with patients. And that's really the glass ceiling that our analytics have been stuck at. You know, when we do the types of analyses where we find genetic associations or epidemiological associations, we're kind of finding one factor at a time. But of course, they interact with one another in unpredictable ways or mathematically in non-linear ways. And you can't get that signal just from looking at one thing at a time. So this combinatorial analysis is absolutely fundamental to understanding that. Then, of course, you've got to have decision support tools that you can put in the hands of clinicians and patients so that they can make sense of this incredibly complex picture and come down to the right recommendation at the right time.
So we really seem to be at the dawn of a new era in understanding the human body and the interaction between these things. Can you just sort of say a little bit more about the role of diet and how this is affected by genetics?
Yeah, well, I'll give you a really good example in type 2 diabetes. You know, so as you know, diabetes is a huge issue for the healthcare systems. Costs about $500 billion to treat in the US alone. And about 80% of that is spent on patients who can't manage their disease. So their A1C is out of bounds. And they go on to have severe disease with complications like renal failure, heart attacks and strokes, neuropathies leading to blindness, or maybe ulcers leading to amputation. And the real challenge for a health system is that it's hard to see who is going to progress to which of those complications and what to do about it, because quite frankly, you know, there aren't drugs for all of those kind of chronic conditions. We're sort of treating around the edges. So one of the things that we've been looking at is a very large-scale clinical trial which has followed 22,000 middle-aged to slightly elderly Americans, and looking both at their comorbidities, their prescriptions, the longitudinal clinical histories, as well as things like diet and lifestyle and interactions socially or with pets, a whole bunch of those kind of factors. And we're able now to segregate with fairly good accuracy what the disease trajectory is going to be for individual patients at the point of diagnosis. And we have a range of therapeutic and pardon me, and non-therapeutic interventions. So, you know, we know that diet is going to has a huge impact on wellness, particularly when you've got metabolic conditions or cognitive decline kind of risk factors. So being able to tease those out and assign them to individual patient subgroups, you know, stops medicine simply being a one size fits all, simply a blockbuster type pharmaceutical intervention. You can go in and nuance that for the particular patient in front of you.
I think that's extremely important, but that still presents you with a challenge. If we're talking about lifestyle behaviours and diabetes too, etc., all the evidence seems to point to the fact for many people with diabetes too, it's actually reversible with the right combination of diet and exercise. So if you get to the point of understanding what it is that in the diet which is going to be good for you and bad for you, how do you then translate that into a behavioural change?
I think exactly the kind of thing that you would recognize. You know, you're giving personalized advice to patients, so they don't think it's eat 5 a day, give up smoking, drinking, do more exercise, one size fits all. It's about them, and they have to be able to see personalized recommendations. They need to be rewarded for making those changes, and they need to be able to see the impact that it has on their health. So constant measurement and correlating those changes in behavior with measurable outcomes that impact on how well they feel. If you can do all of those things, I think you will make a significant impact. It won't
Yeah,
be for everybody, but
yeah, I think you're absolutely right, and I think this is where gamification comes in clearly.
absolutely.
I think one of the challenges when you're designing gamification solutions, they're based on performance and feedback and being able to measure how you're doing. One of the issues with health and diabetes seems to be is how you there's a kind of time lag between your behavior and the impact on your health. That's the difficulty, is getting you to be able to show improvements much quicker than you would do just by simply weighing yourself and doing some of the other things.
Yeah, there are some technological changes to that are coming. So we're working with a patient population who have continuous glucose monitoring, even though they're not necessarily at the sickest end of the patient population. I think also being able to present a disease trajectory and show people how much they're slowing down their progression towards some of the more serious symptoms, when you know what those severe side effect, severe complications and consequences of the disease are going to be, is going to be really important. If you can measure renal function pretty easily, and being able to show people that they've slowed their progression to dialysis, I would imagine is pretty motivating.
Yeah, I can't help but agree with you. And it's been a pleasure to talk to you again, Steve. And I hope to see you in a couple of weeks' time when we talk about nature versus nurture. We've got Dr. Samir Shah, who's been waiting patiently to join us. He's next up. So I'll say cheerio, Steve. Thanks once again. And then I'll invite Dr. Shah to say a little bit about himself. So welcome. Thank you very much for joining me this morning. It's good to see you. We've never met or had any really previous conversation, but you've become highly recommended. And all I know about you is that you won an award with a Dorothy app. So could you begin by telling me about yourself and about the Dorothy app and the award that you've won for it?
Sure. So I'm a consultant neuropsychiatrist, and I run dementia services for North East London. My main patch is an area called Waltham Forest. And we've done a lot of really innovative work in my sort of day-to-day practice, including adding hearing screening, looking at lifestyle factors, trying to stop things actually happening before they start. And a year or two ago, a good friend of mine who's now he's now product director for autonomous driving for the company that supplies Mercedes and BMW. His grandfather was diagnosed with a dementia and moved in with him. And as you may know, half of all carers have a depression, and he became one of them. We really wanted to help each other. And that's really how Dorothy came to be. We wanted to use technology to try and help his grandfather. As you know, a million people with dementia in the USA and Europe depend on a walker. And we're using old tablets and existing, essentially, infrastructure to transform that walker into an augmented reality assistant that's totally bespoke to their needs. It's the only fully interactive, personalized, and mobile monitoring system. So assuming everywhere is scanned in, you can move it from place to place. And as you know, as we get older and older, the places where we receive care become less and less familiar. So they're pretty scary places. And a lot of places aren't set up for having Bluetooth beacons and all these things. So what we want to do is have a standalone device, which is your older device. We just before COVID, we were testing quite regularly in a dementia care home, and our testers, while we're making large modifications to Apple's own system, and what we found was that actually people were walking more. They were navigating these places that they never knew better and finding their rooms. And the really interesting thing about wearables is that those with dementia, this is the first type of wearable, not really wearable, that has been tolerated. So if you give somebody a watch or a pendant, if they have cognitive impairment, you'll find that they'll just take it off, or they won't use it. So whilst we have that tablet on the walker, it also sends real-time data to the carer, so they know how much they are. They know how much they're walking. They can communicate with them in their language if need be, and that is what we wanted to do, was provide that support for carers, because they had information, because we know that carers are often far away, family members are often far away, and they don't receive necessarily good quality information. Yeah, so we know that it affects 50 million people worldwide. It's got $1 trillion annual care costs, going to triple in 30 years. And what we want to do is reduce the burden on both carers and the person with dementia. Currently, we've just agreed to work with Oxford University hospitals. We've been working with Waltham Forest Council. We're also working with the University of Portsmouth. And in terms of this award, it was the World Innovation in Healthcare Award, which is an annual thing that happens. It was the Spark Award for the best early stage healthcare startup. So we're relatively new, but I think we've done quite a lot in that time. Yeah, really happy to answer the questions.
Well, that's a wonderful description, because I could talk from a little bit of personal experience with my partner's father, 95-year-old father. He's living with us at the moment, and his walker is a lifesaver for him. And he is able to use the walker to get about the house, where he wouldn't be able to stand on his own. So this your solution, is it a tablet that sits on the walker? What is the user experience? What does the old person see or hear?
What you'll see is an old tablet. So it's actually is based on, or you can go all the way back to an iPhone 6S. So 4 years old, I think, 4 or 5 years old. And it's mounted to the walker itself. So it's mounted to their personal fitted walker. And what they will see is, essentially, they'll see right through it. The camera will work on the other side and they'll see through it. And they'll see some icons. So what we know is that when one looks at a representation of things with a dementia, there's this thing called posterior cortical atrophy, which happens often later on, but sometimes early, where any lines that are close to each other or complex things, they're really hard to see. So we've designed our icons so that they can see them, that they can be interpreted. And then they will press the icon, or they'll ask an assistant, someone who's there, to show them what they need. So if they need water, for example, they will be able to point towards that. And that's what people have been doing if they can't use it themselves. And then when that comes on, there'll be it's called Dorothy because of Yellow Brick Road. So there's a yellow and black direction. So everyone is. And that's laid on to the route they have to take. So they can do it themselves, or somebody can take them, and they're constantly reminded where they're going and what they're doing, because that's also a big issue, So you might say, I definitely need some water, or I definitely need to go to the toilet. And by the time you get there, you might not remember that you need to go. So we've been thinking in quite a kind of systematic way of what somebody with that kind of experience has, how we can make it as easy as possible, because one of the things you don't want to do is add complexity to a system that's already complex. Yeah.
Yeah, absolutely right, and I am impressed, and I salute you for using the word Dorothy, because follow the yellow brick road, and The Wizard of Oz is one of my favourite films, and in fact I played both the Cowardly Lion and Tin Man in stage versions of The Wizard of Oz, so I can see how all that worked. Well, I'm very excited by what you've said, and I hope we'll have opportunities to collaborate in the future. So I will be in touch with you outside of this broadcast to see how we can work together. Well, we have our next guest in the studio now. Is Freddie McMahon. Freddie's joined us, so I'll say thank you, Dr. Shah, and I'll be in touch with you again very shortly. Please stay with us by all means. Thank you. So, good morning, Freddie. Thank you very much for joining us this morning. I wonder if I could ask you to, first of all, introduce yourself, say a little bit about your background and what your involvement is with aging and the elderly.
Good morning, David. Yeah, my name is Freddie McMahon, and my background is in two halves. The first half was really working for financial institutions in strategy, innovation, and leading change. And the second half really of my career is really in startups around big data, artificial intelligence, but more recently around the area of specialist knowledge, which is the subject of today's conversation.
Okay, so you've had quite a career in industry and innovation, and I'm glad to see, as a fellow grey-haired person, that you still have some sort of fire in your belly. So tell me, what is it that you're passionate about now, and how do you see yourself helping to change the world as far as elderly care and assistive technologies is concerned?
Yeah, it would be a pleasure. For a very, very, very long time, and the ideas really started working in really complex institutions, is the area of knowledge. And in particular, the area of specialist knowledge. And by specialist knowledge, we mean anything where you've got choices that drive different pathways, that drive different outcomes. And lots of examples around regulations, guidelines, instructions, procedures is a very, very common form itself. So this area of specialist knowledge, for some time working in artificial intelligence, I realized there were quite limitations on how far it could really go. And more recently realized that, you know, automation is going to be accelerating faster and faster, but we must find a way where we can have people keeping pace with the rate of change. And so by actually focusing on the area of amplifying people with specialist knowledge to keep pace with the rate of change is really been a long-term fashion. And the area of specialist knowledge is really sort of scattered. It's in people's heads, it's in documentation, it's in content, etc. And if you just look at it from a bird's eye view, you see it's really quite scattered and fragmented and not easy to use itself. So the big dream for some time was, how could we actually take this area that's so intangible and make it into a tangible, working and measurable knowledge asset? And so the whole focus now is we're setting up a new company based on feedback from the market called Orchestra. It'll be launched later this year with an end-to-end platform. And the idea is to deliver knowledge as a service. When you start to look at knowledge in the specialist knowledge as a market, there are so many categories of knowledge. In fact, over 1 million categories of specialist knowledge itself. Then the idea is where to focus. So we've developed a methodology to select on the first two areas that we'll be going to market. One is in the area of from child, looking at the area of child abuse to really going from child child abuse to child safety. The second one will be domestic abuse to domestic safety. But one of the pilots we did to arrive at Orchestra was in the area of the elderly. And we did some work with the Anglo-Ruskin University in the area of back pain. And it turns out back pain is a massive, complex specialist knowledge itself. And like all these things with any category of specialist knowledge, if you can make it easy to use for people, just as importantly, capture the data as people interact with that knowledge and use that data to drive change, to drive interventions, then you can start to develop world-class specialist knowledge and make that more and more available. So the area of elderly, and if you start to look at, well, how many different categories of specialist knowledge apply for that, no one really knows. And so those would be areas we'd be exploring at some stage.
Yeah, so I think it's very important. I'd like to just put a different lens on this, and that is to say that I believe passionately that one of the problems with the aging society is that older people are very often seen as a burden rather than an asset. And when you're talking about specialist knowledge, you and I were baby boomers, I'm presuming. Certainly I was a baby boomer. And so I've seen changes in the world that millennials and young people of today have absolutely no idea about. Because they didn't live through that age. But that's quite a different situation to when you and I were born, because the world that we were born into wasn't really that different from the world that our parents grew up in. But today it's very different. So how do you think we can leverage the specialist knowledge of older people? Is it a question of perception, or how do you see that?
Well, basically, almost the 101 is what is the category of specialist knowledge? And one of the big insights is you can't treat each category of specialist knowledge as if it's the same. So each category of specialist knowledge really requires to attract people that are quite passionate about it, but also bring in diversity and equality. More importantly is having the feedback loops, and because we can now produce, we can digitize specialist knowledge as long as it's readily available. We can digitize it, but once you can start to measure it, once you've got feedback loops, regardless to age or gender, then you can start to make the improvements associated with it. And it's a big difference in the way you start to think. So if it was to do with elderly and back pain, part of the crucial feedbacks on where to improve the knowledge would be the very elderly with the back pain itself. And so there's been books such as Decision Tree, where people get so frustrated with the type of health and medical advice they're getting, that they form their own cohorts and they start to write down flow charts or decision trees to do that. So if you can start to harness the people that are actually impacted, then that harness gets translated to enriching and extending the boundaries of knowledge. Because this big shift from intangible to tangible, we can start to accelerate the learnings of knowledge on the edge. And there's so much talent out there, so much knowledge in people's heads, that the feedback loops from those would actually start to make it better and better and better.
Yeah, I certainly agree with you about that, and I'd like to thank you for joining me today. We're now at the end of our 1 hour broadcast. We've got another broadcast this afternoon at 3:30. So thank you very much for joining me today, Freddie. I'm going to now just finish off by showing a couple of slides to show people what they can expect this afternoon. So thank you very much for that, Freddie. Thank you.
Thank you, David.
So this afternoon we are going to have a different set of speakers. We've got Dr. Tanjit Singh, who's joining us from Singapore, and he's going to be talking about a product called Wellhouse Family. Lucia is going to be with us again, as is Keming Zhu, who's our first guest this morning. But we'll also be joined by Robin Trimmingham, who's the co-founder of an organisation in the USA called the Oldhood Group, specialising in support for older people, and Karthika Bojan, who's the CEO and founder of Brainberry, a solution to help with dementia. So I very much hope that you'll join us this afternoon. But in addition, I'd just like to mention the upcoming broadcast that we have. Our next broadcast on May the 25th will be on the theme of physical fitness, well-being and personal health management. And we're going to finish this series of programs on June the 1st with what I discussed earlier with Steve Gardner, nature or nurture, how do we optimize our personal health? So that won't be the end of Digimed TV. We'll be adding other programs and other themes as we go along. I'd just like to thank those who joined us today for being with us, and it just remains for me to say thank you very much for your participation in today's event, and I hope to see you this afternoon. Thank you.